time. So thank you, Richard, and thank you to the ICEP team for inviting me to speak today on research inclusion. So it's a topic I feel very passionate about. So I hope that this passion comes across to you in my small presentation today. So I'm just going to speak first, hopefully.
It's not moving.
Oh.
Why don't you have to have this in? Oh yeah, that's what you did. Yeah, that's what you did yesterday. Yeah.
Kirsty, can you speak louder?
Louder, yeah, sure. I've got a quiet voice, sorry.
Which is the button that moves it on? Yeah, I believe it's one.
You sorted it out yesterday, didn't you? Yeah. Ah, perfect.
So what do I need to press? Sorry.
It should work.
It should work. Okay. Yeah, brilliant. Thank you.
That's like first.
Thank you so much. So I'm going to first talk about health inequalities. So health inequalities really came to the forefront in the 70s when Julian Tudor Hart coined the inverse care law. So for those of you who don't know, the inverse care law is disadvantaged populations need more healthcare than advantaged populations, but they receive less. And unfortunately, this still continues in the UK and globally. So Julian Tudor Hart, for a bit of history, he grew up in London and he worked in Cambridge as a GP, so he came from a very affluent background, and he actually went and worked in the Welsh mining villages and worked tirelessly to try and improve their health outcomes. So he's a bit of a hero, but unfortunately he died, he passed away not so long ago. But he paved the way for researchers to do more research on health inequalities. But unfortunately, health inequalities is exacerbated if we don't do our health research equally, and that unfortunately there is health research inequity, and then this exacerbates the health inequalities. So this is a study from 2009, so it's a bit of time ago, but the South Asian population, as you know, they're more likely to develop type 2 diabetes than white population. However, there's a lot of the studies, lots of the clinical trials that were done, only 5% in this particular study were represented in that trial, in that study. And also the collection of the data is very poor. And this is improving now. So particularly in the NHS, they've put a real drive into making sure ethnicity in particular is collected well and other kind of protected characteristics. There's been a real shift now, shifting gear into health research inclusion because of the COVID-19 pandemic. So as you know, again, there was research that showed that certain groups were disproportionately affected by COVID. But again, the research, the vaccine trials, the treatment trials, they didn't represent the population that we should be testing. So the NIHR in particular have now mandated research inclusion in all of their domestic calls. So the funders are listening to this. There's been a real, as I said, shifting gear. So if you apply for NIHR funding, you don't incorporate research inclusion in your grant application within your research design, it won't get funded. It's mandatory. And other funders will be hopefully following suit, particularly in Wellcome and MRC funding bids. You do have to include research inclusion, but it's not mandatory at present. And alongside this, the HRA and MHRA, so these are the regulatory bodies, they have also written a diversity plan, which again is moving towards this being a mandatory condition, is you have to get your approvals through your research. You have to make sure that you incorporate inclusive research design. But this is hard. So this is all well and good that the funders and the regulatory bodies are now pushing for this. For us as researchers, how do we apply that to our research? And it's really hard because it requires a lot of resources. It requires extra costs. And so I hope this talk today will just talk about some of those challenges. I'm quickly just going to touch on Cancer Research UK's principles. So because I was invited here to talk to you today, I had a look at their research strategy, and I was pleased to see that their principles at the top: valuing our people, reducing cancer inequalities, involving patients and the public in our research. These are all research inclusion principles. And then I was even more excited to see, sorry, I love research inclusion, or even more excited to see that they had an EDI and research action plan. So the steps that they're taking as a funder to build a more equal, diverse and inclusive research community, in their research strategy, they claim that they're going to ensure fair and inclusive funding processes. They're going to provide career support and development opportunities that attract and support underrepresented groups. And they're going to promote inclusive research design and develop a robust evidence base to drive change. So if we touch on their first principle, which is reducing cancer inequalities, in order to, as I said previously, to reduce cancer inequalities, you would need inclusive research design. And inclusive research needs to be incorporated, if possible, as much as you can, take those small steps throughout the entire research cycle. And here are some just ways you can do this, which some of you are probably aware of, which I've listed on the slide. So building trusted relationships with community groups. So this is your PPIE and community engagement work, which I'll touch on in a minute. Ensuring that your study materials, if you are going out to participants and recruiting participants, that they're accessible. And then dissemination and outputs, which Richard talked about earlier, of communication engagement, making sure that's accessible to as many underrepresented groups as possible. Here are some further strategies. This is a really good website. It is directed to clinical trials, but you can apply a lot of these strategies and suggestions to your research in ICEP. So, as I said, it is hard, but you can put these in place. And funders are expecting now to see you put in these extra strategies and for them to cost more. They're expecting it to cost more to do these things, and they are willing to fund this as an not even seen as an add-on. It's meant to be incorporated within your funding application. So I encourage you all to think about this when you're writing your grant applications. Inclusive research methodology. So the area of work that I work in and the Bristol Trial Centre is that I am looking for evaluating these strategies to make research design more inclusive. And this is one of the studies that I'm doing at the moment. And we're looking at the use of translated documents and interpreting services within clinical trials. So we're looking to see how this is currently done within clinical trials, how much it costs, how much resources are used, because we know, again, this is a huge resource. There's also a lack of training around this, around the use of these language support services within clinical trials. And another study which I'm involved in, which is led by Vicky Wild and Kat Jameson at the BRC, is called the MAPLE study. And this is about making clinical trials more accessible by having an accessible patient information leaflet. So that's the PIL up there. And this was a project we're just about to finish, where we co-produced the accessible patient information leaflet with over 150 different public members, community members, charities, and different groups. It's just been released on the website, so if you want to take a look at it, please do. And we are looking for feedback. So as I said, inclusive research design is difficult, but there are some resources and training out there for you, which you can access. So closer to home, we've got the Inclusive Research Hub, which you may have seen come up on your emails recently. They're promoting this new website, and this has a plethora of resources there for you. We are also developing within Bristol Medical School a research inclusion SharePoint page, which you'll soon be able to access. And then we also have a new short course, which we piloted last year, which is inclusive research processes. But that will be running again, I believe, twice next year. So if you want to learn more about how you can involve inclusive research into your design, then please do attend that course. We also host within Bristol Medical School research inclusion spotlight seminars. So this is where we showcase really good EDI or research inclusion practice within the medical school. So please watch out for those. And then this is not at Bristol, but the Centre for Ethnic Health Research do a really good cultural competency course, which I recommend as well. This is just to give you a flavour of what the inclusive research practice short course is about. So we cover looking at frameworks and guidance that's been published. And we look at mistrust within research, within the communities, within the public, and how community engagement, PPIE, effective PPIE can be beneficial. And then we also look at language barriers and accessibility. And then finally, how to collect demographic data to ensure you're monitoring your research inclusion throughout your research cycle. So moving on to public patient involvement engagement. I won't talk too much about this because Sian and Helen and the contributors will talk about this more in detail. But working with members of the public and communities to embed research inclusion at every stage of your project is really important. So as Richard said, the two kind of intersect, research inclusion and PPIE. Ensuring that your PPI work is diverse, if possible, and then identifying potential barriers to get those communities, patient, public involved in your PPI work is really important because you want them to have meaningful involvement. Now, meaningful patient, public, community engagement involvement is really difficult. So in the past, and unfortunately this practice still does happen, PPIE can be seen as a tick box exercise. So often it can be rushed. It's something just needs to be done for the grant application. Also parachuting in. So people and researchers just parachuting into these communities saying, I need your help with this, and then leaving them and then not coming back. So as you'll hear later on from Sian and Helen, it's all about this meaningful involvement. It's really, really important. And you need to have infrastructure and the people in place to help build those meaningful and good relationships with people. So it can be really damaging if you don't have that. So people and communities, they often feel quite overburdened and felt that they're being used. So it is really, really important that this is done well. As part of my role within the school, I did a scoping exercise of the PPI activity, and it varied massively across the school. So all of the departments and institutes with good infrastructure funding, they had people in place like Helen and Sian to lead on this, build those meaningful relationships. But there were lots of groups who didn't have that at all, and they often piggybacked onto other groups, or they just went in themselves and did the PPIE work, which, because we're all busy academics or busy researchers, we could do this quickly and not so well. It's rushed, so it can be quite harmful to those relationships. And this is the pictorial representation of the PPIE resource across the school. And you can see the large three infrastructures in the middle, and then you've got ICEP, you guys on the side there. And the orange and red blobs kind of are there, showing that there's less funding and less resource there across the school. I did some feedback with members, researchers working in the field, and also public contributors and communities. And they said across the school, we really need a more joined up infrastructure. We need to have a more embedded and sustainable model. There's a lack of funding and lack of resource. And we need to kind of build capacity through training. And there needs to be this equitable relationship with our public contributors, our community groups. So I'm pleased to say that in the medical school, we've got PPIE community of practice, which is going really well. So we're sharing our resources and we're working together. So that's one thing. And we're hoping to also have some funding to fund pre-application PPIE work. And this also, I'm talking about the school now, but this extends out to the faculty. And when you extend out to the faculty, we've got schools that don't have those expertise in PPIE. So it's about trying to make a sustainable model, bring share learning across the school and the wider faculty. My last two slides are just going back to the Cancer Research UK principles and looking at research inclusion in the workforce. So if you go to their research strategy page on the internet, they say that they're going to work in partnership with universities, so yourself, to work towards a fair and inclusive supportive environment, to develop a more diverse research community, and they're going to work with us or you to review and improve funding, to evaluate processes, policies and culture. So these map very nicely onto our new school strategy and the faculty strategy about making sure that we have an inclusive research culture. So on the left here, I've just listed some initiatives that we're working on within Bristol Medical School. This is not an exhaustive list, we're doing other things, but I just wanted to bring these to you today. So these are being currently led by my other partner in crime, which is Dean Knight. And then the corner here, we have the EDI forum for the school. So we're setting up an inclusive mentoring programme. So we're going to be working with underrepresented students within a medical school and match them with academic researchers to work on a research project. So look out for that in your emails. We've also piloted an inclusive recruitment process as well within the school. So we're hoping to roll that out more widely. D is also working on increasing global majority postgraduate researchers and supporting international staff and students, particularly at the moment with the changes in the visas and all the changes in policies and government law. And they're also working on diversifying external speakers that come in and speak at the school. More widely, we're also involved in the faculty EDI group. And they're looking at undergraduate and postgraduate awarding gaps because these gaps still remain with underrepresented groups. We held our first we held our third or fourth EDI event, and there's pictures here of us at the mental health and wellbeing event where I made a massive number of pom-poms, but it was very therapeutic. And we're looking at the impact that the workload model has on quality, diversity and inclusion. As some of you may know, the Athena Swans moved out to the faculty, so we're working on this together with them in the school. And then also, again, they're working on a project to monitor demographics of external speakers. So there's lots of work that we're doing behind the scenes, and I think it maps really nicely onto the Counter Research UK principles. But if anybody's interested in any of this work or wants to know more, please do get in touch with myself and my colleagues. And I think that is the last slide. So thank you very much for your time, for listening. And are there any questions?
They are moving into doing some of their publications into Welsh, Urdu, Hindi, Romanian, and I think Polish, and they're doing some of these are already out and about. And we struggle with that banner on trying to get the range of people in to help do our talks, get out to the people to make the awareness, because we're aware that one white woman going into a very black area, they're not going to listen to you unless you've got a way in. So it's really interesting knowing this is really being driven from the ground up, that it's reflecting what other organisations are already doing, are doing as well.
Yeah.
The other thing we need to make sure we don't miss out is disabled people with long-term conditions and people who are neurodiverse. Because we are not a community, if you know what I mean. There's no such thing as a disability community. But we're scattered all over the place. Mm-hmm. And some, for example, having your literature in audio or braille would help. Or just having a plain English version that somebody on the autistic spectrum would understand. There's so many different groups of people and people with combinations of different things. Most of us don't just have one illness, we have several.
And on that thing, websites, make sure they're screen readable.
Yes.
The whole of the page, not just the bit in the middle.
Yeah.
Because quite a lot will have little columns at the side, which actually then you put to emphasize something, but screen readers can't pick it up.
Mhm.
It's just this image, link, image.
Yeah, there's a lot of work going into communication of different groups, and accessibility is a huge thing, and they are pushing that a lot. So hopefully you'll see some improvements over the time, and we do need to think about intersectionalities as well. So it's just having that money and the resource to do that behind us, and we all as I'm speaking on behalf of everybody here, but we all want to make as inclusive as possible, and that we're restricted what we do. So the work I do is trying to balance the two and try and make it as best as we can and take those small steps. So yeah.
Small steps are better than no steps.
Yes.
Questions? I have one thing that doesn't seem to have been mentioned is data sets.
Yeah.
So because we work, that's what our kind of thing that we do, is work with huge data sets, and we've tried to pull together a new program where we have tried to diversify the data sets. So rather than just being people of European descent, African, East Asian, and so on and so forth, but obviously those data sets are really, really tiny. So compared to the European ones, so there's that issue of how do we, I suppose, all this work in terms of the studies that then go into building those data, it's behoving on funders and so on to make sure that there really is a commitment to funding the collection of those data. Have you got any comment on that?
Yeah, I think again it's a case of us that with the data sets as well trying to catch up. So when new data sets are being made, making sure that they are representative, and in time that will happen. But I guess what you can do as researchers now is just making sure that your dissemination, your public involvement is as inclusive as it can be at this stage. But I think it will just take time for that to catch up, because you can't just create data sets out of nowhere. So yeah, I don't really have a solution.
Yeah, but it's an issue that's going to lag a little bit behind, and sort of try the sort of work we do, it will kind of stop that. But we are making really, really intensive efforts to bring all those data sets together, and things like what you do, Tom, in terms of making them all then publicly available would be one solution, which I think we're going to try and work towards, hopefully. All right, anything else?